Chronic cannabis use exerts a hidden, immense physiological toll on the human body. Processing high-dose THC every day forces the brain into deep neuroadaptation, carrying a systemic allostatic load that the central nervous system must constantly work to balance. While cannabis is widely used for relaxation and relief from nausea, its removal triggers an acute state of agitation and vomiting, the precise inverse of the compound's intended effects. This clinical paradox creates a disconnect between public expectation and reality. While many expect a mild detox, the clinical experience frequently involves severe anxiety, cognitive fog, and intractable cyclical vomiting. This clinical severity separates casual recreational use from what the medical community formally diagnoses as cannabis use disorder, or CUD. The DSM-5 defines this condition through clear clinical impairment, focusing on a patient's rapid development of chemical tolerance and the distinct physical withdrawal syndrome that occurs when THC is withheld. By mapping the timeline of cannabis withdrawal, we can see exactly how chronic THC exposure structurally alters the brain and triggers complex organ failures. Treating modern cannabis use disorder requires discarding the idea of psychological craving. It represents a severe physiological uncoupling of the endocannabinoid system. Acute withdrawal begins within the first 1 to 3 days following complete cessation. Patients report severe irritability, aggressive insomnia, persistent headaches, and a dense, lingering brain fog. The intensity of these symptoms is driven by the modern shift in product potency. Traditional cannabis flower contains roughly 15 to 25% THC. Today's commercial concentrates, often consumed as dabs or waxes, routinely hit 60 to 90%. Exposing the brain to those extreme concentrations triggers a drastic compensatory mechanism. To handle the massive THC influx, the brain initiates severe compensatory downregulation, depleting its own CB1 receptors. Brain fog represents a measurable structural disruption in the prefrontal cortex and the hippocampus. Neuroimaging data reveals that regular heavy users experience a 10 to 20% reduction in fractional anisotropy, a direct measure of the structural integrity of the brain's white matter tracts. This degradation occurs heavily within the frontoparietal networks, which are the pathways responsible for attention, working memory, and cognitive flexibility. The mental fog of early withdrawal represents the brain struggling to transmit signals across frayed white matter pathways that lack their normal receptor density. To measure the long-term cognitive penalty of this structural damage, researchers look to the Dunedin cohort study. This project tracked over 1,000 individuals from birth to age 38, isolating the specific impact of persistent cannabis use on intelligence. This line chart plots IQ over time, revealing a severe cognitive penalty for those who started using heavily during adolescence. This specific cohort lost an average of 8 IQ points by midlife. The most alarming finding from the Dunedin data is what happened when these individuals stopped using. The adolescent onset line remained flat, failing to recover to its baseline even after prolonged abstinence. The trajectory for adult-onset persistent users looks very different. While they experienced a mild initial dip in cognitive function, their IQ arcs back up to the baseline after cessation. For adults or mild users, functional cognitive deficits generally reverse after 72 hours to 4 weeks of abstinence. Adult brains demonstrate resilience and neuroplasticity when THC is removed. Exposing a developing adolescent brain to high doses risks capping its cognitive potential permanently. Moving into days 4 through 7 of the timeline, patients enter the peak withdrawal window, where the physical body experiences its maximum strain. It is during this period that heavy users frequently confront cannabinoid hyperemesis syndrome, or CHS, a severe and underdiagnosed complication of chronic dependence. Clinicians use the Rome-4 criteria to confirm a CHS diagnosis, looking for a history of heavy cannabinoid use coupled with specific, persistent gastrointestinal distress. CHS relies on a biological paradox. Prolonged CB1 receptor desensitization impairs the body's normal antiemetic signaling. The chemical that usually stops nausea begins to actively enhance the pathways that cause it. The syndrome begins in the prodromal phase. For months or even years, the patient experiences morning nausea and a persistent fear of vomiting, though actual emesis rarely occurs.
This eventually breaks into the hyperemetic phase. Patients suffer through 24 to 48-hour cycles of intractable, overwhelming cyclic vomiting, accompanied by intense pain, a presentation often referred to clinically as scromiting. A bizarre clinical hallmark of CHS patients is their compulsion to take scalding hot baths or showers, sometimes remaining in the water for hours at a time to find relief. This behavior targets TRPV1 receptors, which regulate thermoregulation. Applying extreme heat to the skin provides a compensatory pathway that temporarily overrides the dysregulated endocannabinoid system and pauses the nausea. CHS marks a catastrophic failure of the body's endocannabinoid homeostasis. It forces patients to manually manipulate their own thermoregulation just to survive the physical distress. During the hyperemetic phase, these symptoms regularly cross the threshold into emergency medical territory. The constant vomiting creates an immediate threat to the patient's life through severe dehydration, extreme renal stress, and dangerous electrolyte imbalances. Emergency department escalation is dictated by specific red flag symptoms: sudden delirium, syncope, dark urine, and rapid breathing. Beyond gastrointestinal distress, chronic, high-potency daily use exerts a measurable toll on the cardiovascular system. Population data shows a statistically significant elevation in the risk of myocardial infarction and stroke for daily consumers. The method of consumption introduces its own dangers. High-temperature concentrate dabbing creates acute pulmonary risks. Heating these concentrates above 600 degrees Fahrenheit causes terpene decomposition, releasing toxic degradation products like methacrylene and benzene directly into the lungs. The clinical management of acute cannabis withdrawal has evolved beyond managing cravings. It requires active stabilization of failing renal, respiratory, and cardiovascular systems. The recovery phase eventually takes hold. Most acute physical symptoms, including CHS hyperemesis, resolve within 10 to 14 days of absolute abstinence. Neurological recovery operates on a longer timeline. Resolving aggressive sleep disruption, mood instability, and memory processing deficits can take 3 to 4 weeks or longer. During this window, the central nervous system slowly repopulates its CB1 receptors and gradually restabilizes its white matter tracts. Currently, there are no FDA-approved pharmacological cures for cannabis use disorder or cannabinoid hyperemesis syndrome. Traditional antiemetics largely fail to halt CHS vomiting, leaving clinicians reliant on supportive care, IV hydration, and topical capsaicin to manage the distress. Absolute sustained cessation of all cannabinoids remains the only definitive clinical way to break this cycle of neuroadaptation. The recommended strategy for treating CUD relies on supportive psychoeducation, harm reduction pacing, and guiding patients safely through the physical realities of withdrawal. As commercial concentrate potencies climb, the medical community must recognize cannabis dependence as a profound systemic syndrome that requires rigorous, data-driven intervention.